Welcome, everyone, to the fourth webinar of our 2019 series. Today's webinar has been sponsored by Synovian. And I'm Nellie Gontier, Education and Training Specialist for Parkinson Canada. We're broadcasting to you live from Toronto and sending out greetings to those of you joining us from across the country. I want to remind everyone that today's session is being recorded for future viewing. You'll be able to access the recording by visiting our website at www.parkinson.ca or by visiting our YouTube channel, The Knowledge Network. To ensure full compatibility and a glitch-free experience during this session, please ensure you are tuned in using either Google Chrome or Firefox. To report any technical issues at any time during the webinar, please go to the menu at the right of your screen. Use the two admin and ask a question buttons to type in and submit your request. We ask that all questions be reserved for the end of the presentation, at which time our speaker will answer them. We ask that you also keep your questions to a general nature and not solicitous of medical advice. We'll make every effort to answer all questions. We are very fortunate to have with us Dr. Galit Kleiner, who will be discussing the non-motor fluctuations of Parkinson's disease. A non-motor fluctuation in Parkinson's disease refers to the non-movement related symptoms that may fluctuate depending on medication timing. Generally, when medications wear off, it results in the return of tremor, slowness of movement, and difficulty walking and moving. What many people are not aware of is that similar to the motor fluctuations, non-motor fluctuations may also return. This webinar will discuss what non-motor fluctuations are and how to identify them. We'll also be discussing the prevalence of non-motor fluctuations and their impact on quality of life for the person living with Parkinson's. And finally, we'll review effective treatment strategies and current research initiatives targeted at non-motor fluctuations. But before we begin, let me share a little about our expert speaker. Galit Kleiner is an assistant professor of neurology at the University of Toronto. She obtained her doctor's degree from McGill University in Montreal and completed residency in neurology at Harvard University in 2000. She subsequently completed a 2-year clinical research fellowship in movement disorders at the University of Toronto. After starting her career at the University of Pennsylvania as the clinical director of the Parkinson's Disease Research, Education, and Clinical Center, she returned to Canada in 2012 and has since been the medical director of the Jeff and Diane Ross Movement Disorders Clinic at the Assistive Technology Clinic located at Baycrest Health Sciences Center. Dr. Kleiner is interested in quality of life in geriatric movement disorders and is involved in several research initiatives, including non-motor symptom fluctuations, which you'll be hearing about today, and looking at the impact of interdisciplinary care in movement disorders. She has also developed educational materials, including a website, livewellwithparkinsons.com, to enhance knowledge and encourage empowerment for people living with Parkinson's and their families. And with that, please join me in welcoming our guest, Dr. Kleiner.
Nellie, thank you very much for that introduction. And as you have mentioned, our goal today is to discuss non-movement symptoms that fluctuates, meaning those symptoms in Parkinson's that may come and go depending on a certain pattern during the day according to when medications are taken. So first, what we're going to do is we're going to distinguish between what we refer to as movement or motor symptoms, and then we're going to discuss non-movement or non-motor symptoms in Parkinson's disease. The next step is going to be to distinguish between those non-motor symptoms that occur at any time or are constant and are not related to timing of Parkinson's medication versus those non-motor symptoms that change depending on when you take medications, or what we call non-motor fluctuations. So just as a review, I think everybody recognizes, or many people recognize, that Parkinson's disease is a condition associated with impairment in movement. We call those motor symptoms. But more recently, people have come to recognize that Parkinson's encompasses a lot more than just symptoms affecting ability to move, but also many other symptoms, the less visible symptoms, things that can affect thinking and mood, sleep, body sensations, and ability to regulate bowels and bladder. These are called non-movement or non-motor symptoms. So as an example of what we refer to as motor symptoms, symptoms such as tremor, stiffness, slowness, trouble walking, and trouble walking entails slowness in walking, taking small or shuffling steps, freezing when walking, poor balance and falling, difficulty in getting up from a seated position, swallowing difficulties, voice that gets softer, and also involuntary movements. So increase in movements that occur not as slowing down, but actually perhaps excess movements. As examples of non-motor symptoms, I'm going to describe broadly. We can separate these into these following categories: mood and thinking, abnormal sensations, bowel and bladder function, sleep, and energy. So with respect to more details in terms of these broad categories, when I speak about changes in mood, I'm referring to symptoms such as anxiety and nervousness, depression, lack of motivation or apathy, and low energy. With respect to changes in thinking, referring to short-term memory difficulties, generally people have more preserved long-term memory, poor judgment, poor coping, difficulty planning, confusion, hallucinations, and impulse control or poor control over behavior. People may experience abnormal sensations. The most common relates to increased pain, but this may also include numbness, tingling, or others. And the involuntary nervous system or the autonomic nervous system is also affected in Parkinson's, and people may experience changes in their sweating patterns, increased urgency and frequency of urination, and difficulty having a bowel movement or constipation. So what is important is that people recognize that all these invisible symptoms are part of Parkinson's disease, and they aren't just separate entities. Oftentimes, patients and their care partners may not recognize this as part of Parkinson's, but unfortunately, healthcare providers don't recognize it either. As a result, Parkinson's disease non-motor symptoms often go untreated and result in substantial impairment in quality of life. A colleague of mine, Dr. Lisa Shulman in Maryland, was interested in this subject, and she surveyed 99 people, or 99 of her patients that live with Parkinson's, to determine what's the prevalence of some non-motor symptoms. And it's important to see here that she only talked about these 5 symptoms of anxiety, depression, fatigue, sleep disturbances, and sensory symptoms. And what she found was that only 12% of those patients reported that they didn't have any non-motor symptoms. That means that 88% of patients had at least one, if not more. Now, again, as I said, this was not an exhaustive list. She only asked about 4 or 5 symptoms. And we know that there are many, many more non-motor symptoms. And certainly in my experience working with people with Parkinson's for almost 20 years, almost every single patient I've ever met with enough probing acknowledges that they do have non-motor symptoms. So this is a very important category of symptoms to recognize. The second part of the study that she did was looking at the ability of doctors to recognize non-motor symptoms. Now, we're talking about doctors that are neurologists and specialists in Parkinson's. And so in her study, she had the doctors report their immediate impression regarding the presence or absence of depression, anxiety, fatigue, and sleep disturbance after they had a patient visit. All those same patients underwent objective standardized testing to determine whether or not they really did have depression, anxiety, fatigue, and sleep disturbance, and these were compared one to the other. And the study results were quite surprising. The diagnostic accuracy of the treating neurologist was quite poor. They only recognized depression in 35% of the patients that were depressed, 42% of patients that were anxious, 25% of patients that had objective fatigue, and 60% of patients that had sleep disturbances. So the obvious question that comes up is, why are non-motor symptoms not recognized? I think that they're not I think this is a complex question. and it probably has numerous components to the answer. One part of this is that people themselves don't recognize these symptoms as part of their Parkinson's disease. And one of the goals of this webinar is to help you recognize your non-motor symptoms. They may also have a difficult time communicating these symptoms to their doctors. Doctors themselves may not be aware. And doctors, unfortunately, in our healthcare system may not have enough time to probe patients for these symptoms. This slide is just sort of rough prevalences of these specific non-motor symptoms that people may experience. And again, I think this is fairly conservative. I don't think that this really represents the true prevalence of these non-motor symptoms. I think that they occur much more commonly than this table suggests. So one of the goals of this webinar is to help people understand that symptoms of Parkinson's may fluctuate or may come and go depending on the time they take their levodopa medication. So these symptoms that may come and go may be both motor and non-motor symptoms. People often describe the time when their medication is working as the on time and the time when medication is not working as an off time. And this may look like a roller coaster ride throughout the day. This schematic again demonstrates that roller coaster ride and how it and how this may be represented in terms of blood dopamine levels. So here you see this, let's say, is about 7 o'clock in the morning where somebody might be taking their levodopa when they first wake up. It may take about half an hour for the medication to kick in. And then it peaks at about this point. It may be at this point that there could be some involuntary movements, what we call peak dose dyskinesia. And then maybe at 10 o'clock, the medication starts to wear off and the tremor returns and their other symptoms may return. And then they take another dose of levodopa, let's say at 11 a.m. And it takes again another half hour to kick in. And that same cycle may go may repeat itself several times throughout the day. For me as a physician, once I recognize this pattern, it's quite easy for me as I have a toolbox in terms of how to smooth out this effect. And I'll talk about that in coming slides. But I just want to make clear that not every day is predictable in this way. And there may be other patterns that are also fluctuations. For example, there may be a complete failure of on, so people will take their medication and they will not have any benefit, or they may take it and it may take 1 or 2 hours before they recognize benefit, and that's called delayed on. And that's for a whole other webinar to discuss that relates to the metabolism in the gastrointestinal tract related to protein. And I think that's important for people to understand, but it's not within the scope of this specific presentation. So I want to just give you some examples of symptoms that may improve in response to taking levodopa or Parkinson's medications. In the on time, people may experience improvement in their mobility, a reduction or disappearance of their tremor, reduction or disappearance of stiffness and slowness. And as I said, at the on time, there may be also peak dose dyskinesia, so involuntary movements, because there's almost an overshooting of our target for mobility. And which motor symptoms worsen when Parkinson's medications wear off? So in the off time, we can see worsening, freezing of gait. There can be tremor, stiffness, slowness, trouble walking, and muscle cramping, which we call dystonia. Now, you can also see freezing in the on state, and that's a different situation. But for the sake of our trying to get across the point of these fluctuations, this is sort of the most common pattern you may see when people wear off. So again, I just want to make sure that we're all using the same language, because it's important for patients and doctors to communicate in the same way. When people refer to motor fluctuations, they are referring to those movement symptoms of Parkinson's that get better or worse depending on the timing of when they take levodopa. Now, non-motor symptoms may also get better or worse in response to levodopa. So it's important to understand, though, that there's two types of non-motor symptoms. There are those non-motor symptoms that are present all the time and have nothing to do with taking levodopa. And then there's a subset of non-motor symptoms that fluctuate predictably in the same way that the motor symptoms fluctuate. And these are the non-motor fluctuations that we're referring to. And it's important to be able to distinguish these because treatment would be completely different. So what are the treatment strategies I was referring to? My toolbox includes various different options, and they aren't the same for every person. Every person has a different set of symptoms. Every person responds to medication differently. Every person has a different set of side effects that they're at risk for. And so treatment really is customized, and strategies and goals have to be discussed in the context of the physician, the person living with Parkinson's, and their family members as to what they hope to achieve and what risk they're willing to take. Some of the things we can do is we can reduce the interval of timing of levodopa such that instead of taking it every 4 hours, you can take it every 3 hours. There's obviously pros and cons to that. One could increase or decrease the total amount of levodopa that they take per dose. Again, there's reasons to do this, but there's also potential risks in doing this. We can add medications such as COMT inhibitors, things like Comtan, which prolong the effect of the levodopa perhaps by 20 or 30%. Stalevo is a combination of levodopa and Comtan in one pill. Dopamine agonists include medications like Mirapex, Nupro, which is a skin patch, and it's a relatively new medication that we're using, and Retinarol. And then there are MAO-B inhibitors, things like Selegiline and Rasagiline, or Azilect is the brand name. Now, not on the slide, but another option that's very effective to treat non-motor fluctuations as well as motor fluctuations when oral medication just aren't working anymore, or there's too many side effects. And there are those advanced treatments include Duodopa, which is the PEG-J pump. And also deep brain stimulation. And there are specific inclusion and exclusion criteria for when those treatments are offered. So now I just want to make clearer what I'm referring to with respect to non-motor fluctuations with the use of some examples. So here are 3 examples of patients that I work with. The first is an 82-year-old gentleman who has recurrence of tremor, stiffness, and freezing of gait when his levodopa wears off. In addition to having these motor wearing off symptoms, he also starts to experience worsened anxiety, confusion, and anger outbursts. The tremors, freezing, and stiffness, as well as anxiety, confusion, and anger, resolve a half hour after taking a dose of levodopa. So this gentleman has both motor, tremors, freezing, and stiffness fluctuations, as well as non-motor fluctuations, anxiety, confusion, and anger. And they all get better when you take a dose of levodopa. Another example is a 56-year-old man who has a leg tremor and difficulty walking when his levodopa dose wears off. When his levodopa dose wears off, he also experiences incapacitating back pain. So it was only after a lot of kind of probing as to the timing of his back pain that he realized that actually it was as medications were wearing off and not specifically back pain at all times of the day. Tremor, difficulty walking, and back pain resolved half an hour after taking a dose of levodopa. So this example demonstrates that it's not always all good when you take a dose of levodopa. There are also on-period symptoms that can happen, and these are still referred to as non-motor fluctuations. So this was a 59-year-old woman who had an 8-year history of right-hand slowness and stiffness. When she took a dose of levodopa, her stiffness and slowness improved. But within 30 minutes of taking levodopa, she also experienced predictable drenching sweats and restlessness until the levodopa wore off. And in her case, and I didn't write this down, but she also experienced peak dose dyskinesia at the same time. So one of the challenges has been that doctors themselves aren't aware of non-motor fluctuations. And this has been a subject matter for me of great interest for many years. And so it's been a project that I've been working on for many years where we put together a non-motor fluctuation assessment instrument. And some of you in the audience may have even been part of our original focus groups where we queried people living with Parkinson's and their caregivers as to what non-motor fluctuation symptoms they experienced. And after numerous rounds of speaking to many people, we essentially exhausted, hopefully, all the symptoms, and we put together an instrument that we're now in the process of validating. And so this study, which has been supported by the Parkinson Study Group, which is now taking place over 5 sites in both Canada and the United States, is the validation and proving reliable the specific questionnaire to capture these non-motor fluctuations in Parkinson's disease. So why is this study important? Well, I hope that based on the webinar that we've done, you're yourself starting to recognize the importance of these symptoms. Perhaps listening to this, you're thinking, well, maybe I have some non-motor fluctuations. But as I said, in many cases, non-motor fluctuations of Parkinson's aren't well recognized by people themselves living with Parkinson's, their caregivers or care partners, or even healthcare providers. And therefore, they tend to go untreated, and they result in substantial reduction in quality of life. One study suggested that the quality of life was impacted more by non-motor symptoms than by motor symptoms, and caused greater problems. So I'm hoping also with this webinar that we are publicizing our study such that people might be interested in enrolling. The inclusion criteria include having Parkinson's disease, taking levodopa, and having these kind of fluctuating symptoms. So by participating in the questionnaire validation study, you'll come to recognize your own non-motor fluctuations that you're experiencing, and this information can be communicated to your doctor. So what does the study entail? Well, it's actually fairly simple. It's really one visit to our clinic, or actually the Toronto Western Hospital, because we are both study sites, and to answer the questionnaires in the NMOFA. So there's about 28 items that we've identified to be non-motor fluctuations that people with Parkinson's have endorsed. And there may be some additional questions answering other questionnaires just to look to see if there is correlation between our non-motor fluctuation instrument and other non-motor symptom instruments. A doctor or a study coordinator will also do a complete Parkinson's examination, and the entire undertaking usually takes about an hour to an hour and a half. What you need to know to complete the questionnaire includes the understanding that symptoms of Parkinson's can be both movement and non-movement symptoms, and to be able to recognize which of these non-movement symptoms fluctuate depending on when you've taken levodopa. And if people are interested, this Albie Law is my study coordinator, and this is her contact information. And if people are interested after this webinar, they can also contact the Parkinson's Society of Canada, that has been a very, very committed partner in this project and have helped support recruitment. And here are just some other websites for your information. As Nellie had pointed out earlier, we have developed a website that some of you may have already seen called Live Well with Parkinson's. And in that website, there is discussion of medications, protein levodopa interactions, how to troubleshoot some side effects. The website of our clinic, assistivetechnologyclinic.ca, and also the Parkinson's Society website. So with that, I'm going to conclude the formal presentation. Again, I apologize for the technological problems previously, but hopefully everybody was able to pick it up and hear the rest of the presentation. And now, Nellie, I'll hand it back to you, and I'm happy to answer any questions people may have.
Dr. Kleiner, thank you so very much for a very relevant and helpful session. In fact, the comments that were coming in earlier were that the information that you were presenting was so important to our online audience, because I think this is something that generally affects the majority of people with Parkinson's and affects their quality of life more so based on what we hear than the motor symptoms. It was very applicable. It addresses many of the concerns that people with Parkinson's have, and I'm sure that everyone online today has had at least one light bulb moment. So, having said that, before we begin the question and answer portion of our session, we want to remind you that at the close of this session, you will be redirected to a short survey. Please take a minute and provide us with your feedback. Your input is important to us, and it'll help us identify topics of interest for future webinars, as well as help us better meet your needs. So, as we open the forum for questions, let's see. Uh, Dr. Kleiner, do you think you can go back? Because one of the questions is, what's the contact info to participate in the study again?
Absolutely. I thought I would put that slide up so people can continue to have access to it.
Yeah, exactly. And so let me go to, we have an audience member who asks, what about issues with amantadine in addressing Parkinson's related issues and side effects?
Well, amantadine definitely is an important tool that we have to manage symptoms. Primarily, amantadine is used to address dyskinesia. So amantadine in the past used to be, before levodopa existed, and believe it or not, levodopa has been the standard of care since 1969. Prior to that, amantadine was available in other anticholinergic drugs, and amantadine was used to address tremors. So I think that amantadine has some anti-Parkinsonian effects that they aren't as strong as levodopa or some of the other dopamine agonists, but it certainly can be used secondarily to ameliorate some of the Parkinson's symptoms. But really, the main use right now is to deal with dyskinesia. There are side effects of amantadine, and we're careful, especially in elderly people, to use amantadine because it can cause thinking changes. We have to be careful in those that have any compromised renal function because it is metabolized in the kidney rather than the liver. And so people that have any reduced kidney function, we have to reduce doses. It may cause swelling in the feet, so we have to be careful about that. And it may also cause something called livido reticularis, which is not exactly a rash, but some patterning in the skin that almost looks like this sort of lacy, cold, bluish phenomena. It's not dangerous, but people sometimes notice it and are quite distressed by it. So we keep all those things in mind, and as I said, it's part of our toolbox. It doesn't specifically address non-motor fluctuations.
Okay. Another audience member is asking, how can they start this conversation with their doctor?
That's an absolutely excellent question. I'm hoping that with listening to this webinar, people themselves identified which non-motor symptom was affecting them, and what they can do is plot out a diary. What that means is that they write down what time do they take their pill, what time does it kick in, what time do they start to notice their symptom, what time do they start to notice their symptom getting better, and then when does it start to wear off, and when do they take their next pill. We call that a motor diary, where we can plot out this pattern, and based on that pattern, your doctor, a neurologist, usually I think a family medicine doctor may not be able to help, but it would be important that a neurologist, and even better, a movement disorder neurologist, had access to this information such that they would know what to do to reduce these fluctuations.
Okay, and here's a very good question. Another audience member is asking, are age and or gender relevant to the prevalence of non-motor symptoms?
Absolutely not, amazingly. They affect everybody. And interestingly, in some people, the motor fluctuations are minimal and the non-motor fluctuations are much more substantial. So people think, well, I don't really have symptoms of Parkinson's because I don't really have much tremor, or it doesn't bother me much, or I'm walking just fine. But then they have this overwhelming anxiety, and they think that they have a psychiatric problem rather than a Parkinson's problem. So it's important to probe that, but we have not seen any increased prevalence depending on gender or on age.
Okay. So having said that, is there the same type of fluctuation, motor, non-motor fluctuations, with the continuous medication being delivered through something like the Duodopa infusion system?
Another excellent question. And indeed, when we no longer can manage those fluctuations with our armamentarium that is oral medication, that is the next step. And there is some very, very good evidence to support that the fluctuations are markedly reduced. The idea of both deep brain stimulation and the Duodopa system is that there's continuous, in deep brain stimulation, there's continuous stimulation, and in Duodopa, there's continuous administration of levodopa, such that there aren't those ups and downs. That's the whole point of doing the surgery or that procedure.
Okay. Okay. And you've mentioned the non-motor symptoms that are affected. You've mentioned mood, cognition, physical sensations, bowel and bladder functions, even sleep and energy. But does the wearing off of medications also affect senses such as vision, taste, and smell?
Well, you know what? I don't know specifically. I can't answer it definitively. What I can say is that we um, uh, uh, we had many people in our focus groups, and we asked them to provide us the symptoms that they experienced, and these were not the most common. So it's possible that these non-motor symptoms do exist in lower proportions in people. What I would say is that it can definitely, these are non-motor symptoms that are absolutely relevant in Parkinson's, but I haven't seen specific fluctuations related to taste and smell. I've just
Okay.
seen them as non-motor symptoms that are constant.
Constant ones.
Yeah.
Okay. Now, this one's an interesting question from our members. Is apathy a form of depression, and would it be treated differently than depression if it isn't?
Apathy is not a form of depression. And it's a very important distinction because people may see their family member become apathetic, and their family member is not at all sad. They just don't have a motivation to do something. You can definitely see apathy in the context of depression. It is one of the symptoms of depression, but they can exist completely separately, and they probably would be treated differently.
Excellent. Okay. And along similar lines, but another non-motor symptom, are one of our audience members asks, are there any studies dealing with poor judgment, impulse control, that can happen, I guess, with the dopamine agonists?
Mhm.
Hmm.
Absolutely, that's a very big subject, study subject, and we it can happen even with levodopa, not just dopamine agonists, but dopamine agonists. It's probably more prevalent, and we have become very aware of this, and we always have to counsel people that there are risks in taking dopamine agonists. But as long as people themselves are aware that these can be side effects of medications and report them to their doctor if and when they happen, then it can be mitigated. And this will go away completely once the medications are discontinued or reduced. So in the past, before doctors were aware of the fact that these can be side effects, people went and gambled and lost their entire fortune, not recognizing that this was a side effect of medication. In fact, at some point a few years ago, I believe there was a class action lawsuit against one of the companies that made one of the dopamine agonists because of the fact that people didn't recognize this and significant damage occurred as a result of the side effect. But now all of us who prescribe dopamine agonists inform patients, query patients, and as soon as we hear any sign of this kind of symptom, we modify the prescription. However, it's important to note that while this can happen, It does not happen to everyone. It happens maybe to 10-15% of people, and it can be completely managed and stopped once the medication is discontinued. So awareness is really the most important thing.
Okay. I'm going to take this opportunity, Dr. Kleiner, just to mention that we have tools here at Parkinson Canada that will help people with Parkinson's and their care partners track, record, and basically find the patterns in their non-motor symptoms as well as their motor symptoms. So if you want to reach out to our information referral associates, they can guide you to those tools that will help you the best, whether they are the non-motor symptom questionnaire or the Act on Time disease summary sheet or our navigator that can be utilized to do all of this.
That's incredibly important, and I'm really happy to hear that. I know within our own clinic we certainly have these tools, but I'm very happy to hear that you have these tools for the general population that doesn't necessarily have access to a movement disorder clinic. And people should know that this is a very hot topic in research, and technology now in Parkinson's disease is becoming there's a whole movement disorder society task force that is now been assigned to look at education for patients as well as various different technologies to track symptoms. So there's all kinds of sensors and there's apps and all kinds of things. So I think over the next 3 to 5 years, there's going to be a substantial improvement in our ability to monitor and track symptoms, and immediately this information will be available to physicians.
Excellent. And Leslie has a question here. She's asking us to discuss shortness of breath, also known as dyspnea or labored breathing, as a non-motor symptoms. What can you tell us about that? This is very important to recognize this as a non-motor fluctuation, because I have seen on many occasions patients of mine who have had the shortness of breath, who have gone and had all kinds of unnecessary and risky studies, including cardiac catheterizations and all kinds of bronchoscopy and pulmonary assessments, and it has nothing to do with the heart or lungs. It has only to do with Parkinson's and with the fluctuation. So this is a non-motor fluctuation. And once we were able to recognize the pattern and smooth out the response to levodopa, the dyspnea went away. Now, I have to qualify, it can be either an off symptom or it can also be a respiratory dyskinesia. So it can be a peak dose effect. So again, it's important to track when the symptom is happening and its relationship to levodopa. Oh, thank you for that, because I just learned something new. And that is so important, so very important. And on that same line, how is the severity of the motor symptoms correlated with the severity of the non-motor symptoms? As I had mentioned previously, there may be absolutely no correlation. It's very possible that the motor symptoms are very mild and the non-motor symptoms that fluctuate much more severe. And in fact, one of the things that we're doing in our non-motor fluctuation assessment validation study is looking specifically at that relationship between motor fluctuations and non-motor fluctuations and the severity of those, as well as the doctor's impression of the severity of the fluctuation versus the patient's impression of the severity of the fluctuation. So that's a very good question. And I think people make the assumption that the non-motor fluctuations would be as severe as the motor fluctuations, but there really isn't a relationship. Well, I've got another loaded question then. All right. You're doing a wonderful study, very valuable, and I can't wait to read the results when the paper comes out. But in the interim, what would you say is the single most effective means of educating physicians on the non-motor symptoms and fluctuations of Parkinson's disease? We certainly, as physicians, have a job to do on our field. I think that the single most important thing is that patients educate themselves. And unfortunately, patients may have to be educating their doctors as well, saying, look, I'm having these fluctuations. This is related to my Parkinson's. If doctors aren't recognizing this, or you're not feeling that you're getting the kind of care that you need, one of the other initiatives that we're trying, again, as a task force within the Movement Disorder Society, is to push for early referral to movement disorder clinics. So not when people get into trouble, but earlier on
when we can recognize the subtler problems and maybe avoid them or manage them earlier on. The best thing to do is for patients themselves to be empowered in their knowledge and recognize their own patterns. I mean, they're the experts. They're the experts in themselves. So while I think that there's increasing education for physicians, and we're constantly asking ourselves, how do we, how do we as movement disorder physicians ensure that general neurologists and family doctors are learning the things that they need to know? As I said, we're putting together this website, and hopefully it will have broader reaches than just locally. So hopefully, with time and research, people are learning more and more about Parkinson's and how to best help people living with Parkinson's.
Thank you, Dr. Kleiner. I think we've got just enough time for two more questions. One of them's a quick one. What's the difference? Is Prolopa the same as Levodopa?
Prolopa and levodopa are the same in the sense that they have the same so it's not levodopa, it's levodopa carbidopa or Cinemet. Cinemet's the brand name. Levodopa carbidopa is the generic, and benserazide, which is Prolopa. Levodopa benserazide is Prolopa. Levodopa carbidopa is Cinemet. The only difference is the benserazide and the carbidopa. Both those components have nothing to do specifically with dopamine or treating symptoms, but they protect the dopamine from getting metabolized in the bloodstream such that it can get to the brain and then deliver its effects on the brain, because we don't want the levodopa to get converted into dopamine in the bloodstream, because then it causes side effects such as nausea and drop in blood pressure, etc. So it's important and different people respond to levodopa carbidopa differently than levodopa benserazide. It's been my kind of anecdotal experiences that those people that have side effects with levodopa, such as nausea, such as dropping their blood pressure, such as feeling sleepy, do better with Prolopa than they do with levodopa carbidopa.
Okay. And here's a very large question. Is there any information that our audience can find regarding Lewy body dementia versus Parkinson's dementia?
This is a really loaded and complex question, and the reason I say that is because there's ongoing debate within the doctors doing research in Parkinson's disease as to, are these distinct entities or is this a spectrum? So Lewy bodies are protein inclusions that you see in the brain of people with Parkinson's disease as well as Lewy body dementia. Lewy body dementia. Previously, it was thought that Lewy body dementia, those Lewy bodies occurred earlier on in the cortex of the brain, affecting thinking and visual hallucinations, as opposed to Parkinson's disease dementia, when those Lewy bodies happened at a much later stage. We think that this is a spectrum, and it's very difficult to distinguish. Clinically, what we find is that people with Lewy body dementia are very, very sensitive to levodopa medications, and it can really exacerbate their cognitive symptoms and visual hallucinations. So we have to be very careful in using levodopa. Those with Parkinson's disease dementia may also have exacerbation of their cognitive issues and hallucinations with levodopa, but it generally tends to happen at a much later stage. There are a lot of there's a lot of information on the web related to Parkinson's disease dementia versus Lewy body dementia. My concern is that a lot of it is technical, and it may be very difficult for people to be able to really interpret, a layperson be able to interpret and understand the subtleties. And maybe that's a very good topic that we should be considering addressing within the Parkinson's Society of Canada to provide people a better understanding of the complexity of these disorders.
Thank you. That was wonderful. And if you're willing to come back perhaps next year and help us out with that, we'd be so honored to have you. You've mentioned pain as a non-motor symptom of Parkinson's. And how common is back pain, for example, in Parkinson's? And are headaches a non-motor symptom?
So these are all excellent questions, and what I find with regards to pain is that people, I mean, they may have independent pain, meaning that as a wearing off, they experience pain in a body part that they might not otherwise experience, like abdominal pain or so. But with respect to back pain, what tends to happen is that people have an underlying degenerative disc disease, which is very common. We all have arthritis as we get older. It may cause us some problems. That pain gets much worse when when medications wear off. So there may be already an underlying objective substrate for pain, but that pain sensation is exaggerated when medications wear off. So even though by taking levodopa you're not curing the disc disease or the arthritis, the experience of pain may be reduced by reducing the fluctuations.
Okay.
I'm sorry. You also questioned the question of headache.
Headaches,
So
yeah.
I can't answer that question, without any qualifications. I'd need to know more information. People can have headaches for all kinds of different reasons. Headache is very common. It may or may not be related to Parkinson's. One way that I could see where there could be a relationship relates to the tension in the neck, so the stiffness, the axial rigidity, and that may result in referred pain to the temples. So I think each person with a headache would need a more kind of detailed assessment by a doctor to determine what the cause of their headache is and how to treat it.
Yeah, excellent. And one other question, and I think this will be the last one because we've taken up so much of your time, Dr. Kleiner. Is excessive or obsessive focusing on topics or subjects a non-motor symptom?
It absolutely could be, and it could also be a side effect of medication. So part of that impulse control disorder. So when people are fixated on something, that absolutely needs to be recognized and and if they're on a dopamine agonist, it would make sense to review that. But again, I can't just give these blanket answers because it all depends on the circumstances. There are people that are preoccupied, for example, with their bowels because they have such a terrible constipation and it causes them so much pain. So, it makes sense that they'd be preoccupied with this, and the treatment is to manage the constipation and the bowel and so forth. But, there can be a separate and independent psychological or psychiatric preoccupation that needs to be assessed and treated.
Oh, thank you so much. I think that's all the time we have for Q&A. I recognize and acknowledge that some questions may not have been answered. If your question was not answered during this session, please reach out to our information and referral associates, and we'll do our best to give you the answers that you need. To our audience members, a reminder to please complete our survey online so we can bring you the programming that you want. Parkinson Canada really values your feedback, and it is through this feedback that we determine the content of future programs. On behalf of Parkinson Canada, I want to thank you, Dr. Kleiner, for an absolutely wonderful and so relevant. This really did touch on the information that our clients, our community wants answers for. I also want to thank our event sponsor, Synovian, and all of you online for participating in today's webinar and for supporting us in bringing you the conversations that resonate. For more information on non-motor fluctuations in Parkinson's disease or to access a recording of this webinar, please visit our website at www.parkinson.ca. And if you have any other questions, as I said before, regarding today's session or, going beyond what we've discussed today, feel free to contact us by email at info@parkinson.ca or call us toll free at 1-800-565-3000. And as we sign off, Parkinson Canada would like to wish all of you a wonderful day. Dr. Kleiner, thank you again so very much.
Thank you. It was my pleasure. Everyone have a good day. Bye-bye.